Today I'll be discussing middle school mental health literacy education. I'll describe the rationale for mental health literacy in middle schools. I'll define mental health literacy. I'll summarize the results of a scoping review we've done. And finally, I'll describe the development of ADAP junior high. Mental health disorders usually begin during childhood and adolescence. In 2019, 8% of children and 14% of adolescents were affected by a mental health condition. UNICEF found in a global survey that anxiety and depressive disorders account for about 40% of mental health diagnoses in 10 to 19-year-olds, as shown in the graph below, alongside other common conditions for this age group. Anxiety disorders typically emerge earlier than depressive disorders. Both anxiety and depressive disorders increase in prevalence with age and in rates over time, particularly after the COVID-19 pandemic in youth. Anxiety and depressive disorders are leading causes of disability in youth worldwide. In this graph depicting disability-adjusted life years, with males on the left and females on the right, you can see that starting as young as 5 to 9 years old, anxiety disorders begin to significantly impact functioning. And by 10 to 14 years old, depressive disorders also become a significant source of disability. UNICEF found worldwide in 2019 that suicide was the 4th leading cause of death for adolescents aged 10 to 19. And suicide was the 2nd leading cause of death in North American 15 to 19-year-olds. This graph depicts data from the WHO illustrating a steep increase in suicide deaths between the ages of 10 and 20 years old. In the United States, suicide rates for young people 10 to 24 years old have increased from 2007 through 2021. Suicide prevention and the importance of youth mental health have been an ongoing focus of the U.S. Surgeon General since at least 1999. While risk for suicide is complex and multifactorial, it's also mitigable. Anxiety, depressive disorders, and the stigma associated with both mental illness and help seeking are important contributors to suicide risk. Early diagnosis and appropriate mental health treatment can make a difference. International surveys demonstrate that many do not seek professional help or delay seeking help for many years, worsening prognosis. And we saw an example of that today with our patient. While barriers to receiving mental health treatment are numerous, recognizing a mental health disorder is the most predictive factor of youth seeking treatment. It is generally agreed upon that today's schools must offer more than academic instruction to prepare students for life. The CDC's Division of Adolescent and School Health released an action guide in December 2023 to promote youth mental health in schools. The first strategy is to increase students' mental health literacy via universal, Tier 1, school-based programming for all students. The guide cites the original Adolescent Depression Awareness Program, ADAP, as an example. Classroom mental health literacy curricula are associated with improved mental health knowledge, attitudes, help-seeking behaviors, optimism about treatment effectiveness, and decreased stigma. Anthony Jorm and his colleagues coined the term mental health literacy in 1997. And define it as including the following components: the ability to identify specific mental health disorders, attitudes including stigma towards mental health disorders which affect illness recognition and help seeking, mental health risk factors and causes, the professional treatments available, self-help strategies, and resources to find valid mental health information. Middle school youth include pre-adolescents through early adolescence, 10 to 14-year-olds. They have developmental needs that are different from older high school students. Entry into middle school, 5th to 8th grade in the United States, requires a higher level of functioning than is expected in earlier grades. There are more academic demands, lower levels of adult support, and increasingly complex social relationships. Developmentally, the search begins for self-identity, and it's a time of fluidity and flexibility in self-concept. Pre-adolescents have a developing sense of understanding emotions and perspective-taking. They're learning to accept and to be accepted. They become more idealistic, which can lead to unrealistic expectations of themselves and others, at times leading to frustration. 75% of 10-year-olds state that they themselves, not a parent or adult, know best about what they are thinking or feeling. Thus, it is a time when youth begin to draw adult authority into question, and peer identification grows increasingly potent. The pre-adolescent's apparent capacity for self-reliance masks the reality that they still depend heavily on their support systems. And thus, it is important to be thoughtful about what these younger adolescents are exposed to, and that their educational materials are developmentally appropriate. The 2021 CDC Middle School Youth Risk Behavior Survey indicated that in the United States, an average of 23.2% of middle school students report their mental health as recently not good, most of the time or always, with an average of 27.1% reporting seriously thinking about killing themselves. You'll notice on this map there are fewer locations which participate in the middle school youth risk behavior survey compared to the survey for high school students. There are an average of almost 20% of middle school students having ever made a plan about how they would kill themselves, and an average of 10.8% having ever tried killing themselves. There's often a concerned voice that talking about suicide with youth will inspire them to consider it for themselves. This data shows that they're already thinking about suicide and taking action in suicide attempts. And we know as clinicians that to not talk about suicide is a disservice to these youth, in the same, or as would recklessly glorifying suicide as something other than one of the most serious symptoms and potential tragedies of undertreated mental illness. To learn more about the current state of mental health literacy education for middle school students, we conducted a scoping review of universal school-based mental health literacy programs for these middle school students. As you may or may not be able to see on the flowchart, after removing duplicates, we reviewed 4,902 titles and abstracts, 346 full texts, and then hand-searched 40 related review articles that had been excluded. We included articles describing programs implemented universally in schools during the school day, with greater than 50% of students in the equivalent of US 5th to 8th grade, with a mean age of 10 to 14 years old, and measured outcomes published in English. Program content, at a minimum, had to teach the ability to identify specific mental health disorders. The top two reasons for exclusion were less than 50% of the student audience meeting grade or age parameters, or not describing content satisfying the ability to identify a specific mental health disorder. Many well-known universal school-based mental health literacy programs have not yet published regarding implementation with this age group. Most published studies pertain to older high school students. We identified 31 articles describing 24 programs, published between 1993 and 2022. The largest portion were from the US, though programs have been implemented in many countries. Over half, 14 programs, were specifically designed for middle school students, at least in part. And less than half included at least one physician in their development or research team, though this was often not described. 12 studies were randomized controlled trials, 8 had no control group, and others were a variety of other methods, including qualitative studies. Between 30 and 6,386 students were sampled in the various studies. Student ages ranged from 8 to 16 years old, with mean ages between 10.6 and 14 years old. The students were in the equivalent of US 5th to 8th grade, at times described as secondary or high schoolers internationally, but they would meet age criteria if they were included in our scoping review. The length of follow-up varied from immediately post-intervention, which was true for 8 of these studies, to a maximum of 30 months. No two programs had the same implementation. 8 programs were facilitated by classroom teachers, usually science, English, or health, physical education, and 3 programs by other school staff, such as counselors or nurses. 11 programs, less than half, explicitly trained their facilitators. The amount of classroom time needed varied from less than an hour to 12 hours, most commonly 1 to 3 hours, which was true in 8 of the programs. All but 1 program, which lasted 2 years, described a school year duration of less than or equal to 3 months, and the programs were a single session in 25% of the programs. Cost was typically not described. 3 programs with sponsors were free of cost to schools. Harry Potter CBT, which I'll talk more about later, was sponsored by Google Canada. The Science of Mental Illness, sponsored by NIH and IMH, and Breaking the Silence, sponsored by NAMI. No two programs had the same curriculum. Only 1 program taught all 6 components of mental health literacy, as defined by Jorm and his colleagues. That program came out of Oregon, taught by school nurses. 13 programs, over half, had anti-stigma content, and the same portion had self-help strategy content, though only 3 programs covered both topics. Less than half of the programs discussed causative and risk factors, even less discussed the treatment of mental illness. Thankfully, 70.8% discussed depression literacy. 13 programs, just over half, mention anxiety, though not always enough to identify an anxiety disorder. And only 7 programs mentioned suicide. 5 programs covered all 3 topics, depression, anxiety, and suicide. And of those 5, only 1 has psychiatrists involved in the research and development team, which is Harry Potter CBT, more to follow. Over half of the programs talk about how to seek help, and over half discuss either first aid skills or additional coping skills like mindfulness or CBT. And qualitatively, there's no consensus on what content students prefer. No two programs had the same educational strategies. 87.5% included some type of student activity. Over half had didactic presentations. 9 programs had some sort of student assignment, and 4 programs had contact with an individual with lived experience. 1 program, Eliminating the Stigma of Differences, which I'll also talk a bit about in some more slides, had all 4 of these educational strategies, and 25% of the programs used at least 3 types. In terms of measured outcomes, 21 of 22 programs showed some improvement in students' knowledge of mental health. This was non-significant in 1 case, and another program showed no effect on the recognition of depressive symptoms. 13 of 16 programs showed a reduction in stigma towards mental illness post-intervention through 2-week follow-up. Though in 5 cases, at longer-term follow-up between 3 months and 1 year, this positive finding faded. The anti-stigma effect was maintained at a significant level in only 1 program at 2-year follow-up, the Eliminating of Stigma of Differences program, which I'll talk more about later. 11 programs showed some degree of improvement in help seeking, though this was fairly nuanced when you dug into the data. And in 7 qualitative studies, the programs were found to be acceptable. In 5 programs, there was significant improvement in at least 1 mental health outcome. 3 programs evidence a positive effect on at least 1 measured aspect of suicidality, though this is measured differently in different programs. 3 programs showed a positive effect on a measured aspect of anxiety, and only one program evidenced a positive effect on an aspect of depression in at least a subgroup. Notably, Harry Potter CBT shows positive effects in all three categories. At least 9 programs in our sample found no significant improvement on at least one measured mental health problem outcome for the universal student population. So since we've been talking about it, a little bit more about the Harry Potter-based CBT skills curriculum. As discussed, this program showed a positive effect on suicidality, anxiety, and depression in the students who received it. Notably, these studies anyway did not measure mental health knowledge or stigma. The program in a qualitative part of the study found that help seeking depended mostly on relationships that students had. So this main study was a randomized control trial in Ontario, Canada, with follow-up immediately post the intervention. Trained English teachers taught grades 7 and 8 students 11 to 14 over 3 months using the third Harry Potter book in the context of English class. The content included identifying depression, anxiety, and other mental disorders. Suicidal ideation was described as a symptom of depression. Risk factors and causes were covered, as were how to seek help and some self-help strategies. Group discussion and written student assignments were used, and this program was free to schools as Google Canada sponsored website development, making the program accessible. Another program mentioned is the Eliminating Stigma of Differences program. This is the one program to show a sustained anti-stigma effect. It was studied by a randomized control trial in Texas. There's 2-year follow-up. The program was delivered by health education teachers in 6th grade with a mean student age of 11.5 years old. The program lasted 3 hours, delivered over 3 to 6 days. The papers describe no prior specialized training for the facilitators, though there is a detailed guide and an instructional video. The content included identifying depression, anxiety, suicide, and other mental health disorders, risk factors and causes, treatments, and anti-stigma content. Educational strategies included didactic presentations, group discussion, homework, and contact with a young adult with lived experience. And the cost was not described. In conclusion, we learned from our scoping review that there's a lack of consensus on core mental health literacy curriculum, also a lack of consensus on the best implementation practices, and a need for more standardized, rigorous study of outcomes to improve effectiveness of these programs. We also thought it was important to clarify the suicide prevention aim of these programs that's often discussed. The programs, we believe, are not directly preventing suicide themselves, but instead will increase the likelihood that early adolescents will get the treatment at the right time by universally imparting the knowledge necessary to increase help-seeking behaviors and mitigate the risks that can then lead to suicide. There are ongoing mental health literacy needs for middle school students. As we've discussed, the existing programs with mental health literacy components vary widely. Many do not include all components of mental health literacy, nor aim to improve mental health literacy. Many programs demonstrate success with high school students, though there are fewer for middle school students. Recent broader scoping reviews of mental health literacy programs have indicated that an intervention should focus on youth less than 14 years old. And middle school students certainly have a need for and receptivity towards this type of education. And anecdotally, ADAP schools have been asking what to do about anxiety and what to do for middle schoolers for years. And thus, we are developing the ADAP Junior High program with a team of medical students, residents, fellows, and faculty, including multiple child and adolescent psychiatrists and mood disorder experts. And ADAP for us is going to stand for the Anxiety and Depression Awareness Program. We had our first brainstorming session in 2021. The goal of ADAP Junior High is to continue to do what the original ADAP team learned works well, and to customize the content to fit the needs of middle school students. In ADAP Junior High, we will focus on anxiety because we know that anxiety disorders typically emerge earlier and often predate depression. The content will be organized into 9 shorter modules to accommodate younger learners. Each module will include an animated video to deliver uniform content in an engaging way and to avoid asking children to share personal experiences. Each module will also include a specific activity designed to teach a skill or otherwise reinforce application of what they learned. These might include role play, games, projects. We will follow the same model developed for the original ADAP of training school-based professionals online to then educate their students during the school day. And delivery of the modules will be flexible, allowing for splitting or grouping to accommodate different school schedules. ADAP Junior High will cover all 6 components of mental health literacy. We will teach the ability to identify signs and symptoms of anxiety disorders, depressive disorders, and to recognize thoughts of suicide as an emergency. We will assess student attitudes, including stigma towards mental health disorders. We will discuss risk factors and causes of anxiety and depression. We will discuss the professional treatments available. We will teach self-help strategies, including a coping skills tool belt module. And we will identify school-based resources, including school counselors, for students to seek additional information. To give you a sense of the module content we're developing, what is stress? Identifying that the right kind of stress can help us learn and grow, like physical exercise can build muscles and stamina. Identifying emotions and why we have them, to signal to us and others when something important is happening. What are fear and anxiety, and what they might look like, including combinations of thoughts, feelings, and behaviors. Helpful and unhelpful anxiety, for example, feeling anxious about a test in 2 days might promote studying, or might overwhelm someone so much they don't go to school and don't take the test at all. When is anxiety a medical problem? When anxiety is so strong and so frequent that it makes someone feel so unwell they avoid doing the things they need to do or want to do. Be brave, do the thing that scares you, the basic idea of anxiety treatment. A coping skills tool belt, introducing simple examples of distraction, breathing techniques, mindfulness, and self-compassion. A discussion of values and goals to help identify the important things that motivate a student to be brave despite the anxiety. And most importantly, what to do, talk to an adult, as in the original ADAP, emphasizing that no one deserves to struggle alone, and how to identify an adult who can help and connect students with appropriate treatment. Thanks to the generosity of many donors, we have begun working with an animation team. And in just a few minutes, I'll show you a brief trailer of our first video for the helpful and unhelpful anxiety module. You'll notice our narrator character hovering around this young person who will appear in all program videos. Currently, we're developing the program with an initial focus on creating the animated videos, which we are learning is a complex process. We had to fire our first animation company as their experience creating videos for corporate America didn't translate well. We'll collect iterative feedback from clinicians, students, and teachers to finalize the curriculum. And we also plan to create an online facilitator training program, as the original ADAP demonstrated that facilitators with better mental health literacy themselves were more effective teachers. We want them to have the information they need to teach complex topics with the appropriate nuance. We're committed to ADAP Junior High being accessible to all schools by making it free of cost. By building on the original ADAP program's expertise, website, and relationships with schools, we hope ADAP Junior High may achieve broad dissemination more quickly. For example, from the website, when an educator clicks Start Teaching Today, they'll be able to choose to complete a web-based training in ADAP Junior High for their middle schoolers, or the original ADAP for their high school students. In conclusion, universal school-based mental health literacy programs are associated with improved mental health knowledge, attitudes, help-seeking behaviors, optimism about treatment effectiveness, and decreased stigma. Recognizing a mental health disorder is the most predictive factor of youth seeking treatment to mitigate the risk that can lead to suicide. There are few programs for middle school students. They vary widely, and the outcomes are mixed. Building on the original ADAP program's expertise, technology, and relationships with schools, ADAP Junior High may achieve broad dissemination more quickly. And so I'm going to pull up our hot off the presses trailer for our first video. We just got it on Friday. We haven't yet had the opportunity to influence the music or the voice. So ignore those parts, but enjoy the animation and the script.
You've probably noticed that...
Hold on. That's not moving the way I want it to.
You've probably noticed that there is a wide range of anxiety, some that is clearly helpful, some that is clearly not helpful, and much that is somewhere in between. Anxiety is a normal part of being human. Anxiety typically comes and goes over time and changes as a person grows up. Sometimes repeatedly choosing to do the thing that you need to do and want to do is the best way to eventually, slowly turn down the volume on anxious thoughts and feelings, and turn up the volume on thoughts and feelings that may help you move towards what is important. When you are anxious, ask yourself this question: who wins if I make this choice? Me or my anxiety?
So that's just a sneak peek. It'll be a longer video and a little bit less sad, I hope. But I'm happy to take any questions. Thanks for your attention.
Thank you, Dr. Zachik. That was great. Yeah, the video looks terrific. The animation looks really nice. Great presentation, great work. I love the project. And I guess that my question for you is, I'm trying to imagine what it's like working in middle schools with kids 10 to 14. You're a child psychiatrist. You have lots of child psychiatrists on the team. I know you've given this a ton of thought. I guess I'm wondering in particular about how do you maximize the degree to which kids take this seriously and minimize the amount of kind of goofing off and heckling and you know, all sorts of stuff that kids that age can sometimes do, especially with a topic like this where you can imagine kids making fun of other kids?
It's a great question. To try to summarize, how do we make sure the students take it seriously, I think. I think that's something that we will probably rely on our educator colleagues to help guide us and make sure we don't make silly mistakes as we're continuing to design it. I think having the teachers themselves deliver the content, and if not the teachers, someone else in the school, will help. It's a familiar face, someone they have a relationship with already, and someone who will know the kids, we hope, and sort of thus be able to make those nuanced decisions that might make it sort of more palatable to a particular audience. So I think relying on our colleagues to make those in-the-moment judgments.
Makes sense, yeah. Good, thanks. Folks have questions? Dr. Campo.
It's a really good question. Just to summarize, in those creating and studying mental health literacy programs for students, are we looking at the correct outcomes? In reviewing the literature for the scoping review, almost every study is measuring something different. They're using different types of scales. Some of the scales are often created for the particular study. It's a good question. Probably yes and no. I mean, we want to make sure that some of these process things are looked at. I think some of the difficulty and challenge is how do you really study help-seeking behavior in a young person? other than sort of watching over time. Because I think at the end of the day, that's really what we'd like to see, that they're really reaching out for help when they need to. And I think it's hard to study.
I guess the question is help-seeking behavior the proper outcome, or is it beyond that, right? Is it, if you seek help, are you less likely to engage in suicidal behavior, or die by suicide, or suffer from it? And, another aspect is what's the relationship between stigma and the outcomes that we're aiming for. And I think these are difficult. The process measures are important, but then the question is what's the relationship between process and outcome?
You're right. We're making some assumptions, but you're right. There's a lot of unknown, a lot of work to be done in the field.
Sure, but it's a start, so thank you for doing it. And just a suggestion, I think we could go music. I make a few songs by characters.
Other folks? Who is that out there? Oh, yes. Dr. Wilcox.
Yeah, to summarize the question, have we asked middle schoolers what they think yet? And the answer is not yet, but it's part of the plan, definitely, because they're the most important part of this, really.
So that's still to come.
Yeah.
Dr. El-Zamazami.
To summarize the question, there's a New York Times article that I regrettably have not read, but have heard a little bit about. And the question of, gosh, if we're talking about it, are we creating a problem that's not there? I mean, I think as child psychiatrists, we know that it's there. I think it's important that kids are able to talk about it and talk about things that maybe they don't even quite know what it is yet, hopefully to prevent a story like we saw today with our patient where they notice something's not quite right and they have to turn to Google to try to figure it out. Also, as child psychiatrists, I think we have, and perhaps our adult colleagues as well, I think, it's not uncommon for some of our patients and families to come through the door with various hypotheses of what is happening, sometimes with very strident opinions of what to call it and not to call it. I think that's an okay problem to have. I think the fact that the conversation is happening is what's most important. I hope that kind of answers your question.
In terms of the extent to which it's there, I was really struck by one of your slides on percentage of kids in a national polling data, survey data that had thought about the idea of suicide. I think it was 20% of these kids had thought about it. That's a big, big chunk.
Yeah, almost 20% had a plan.
Is that what it was?
Almost.
Okay. Right.
Over 27% have thought about it.
Right. Dr. Scharf.
Thank you for the question. To try to summarize, what has it been like engaging with our animating colleagues in trying to realize our vision? It's a really good question. I was a creative writing major back in the day, and drew upon one screenwriting class to make the scripts for our video. So who knew that would come in handy? So it's nice to have at least a toe in the water in that world, but obviously there are many things that I don't understand and have a lot to learn. It's been a little bit more challenging than we expected. As I said, our first animation company wasn't getting it, despite many emails and meetings. However, our new company is amazing, and really, even just from reading the script I wrote, got it, and a lot more easily than the first group. So I think there's a lot for us to learn, maybe is the first thing to say. But I think probably like any project, finding people that kind of get it, kind of get you, is maybe an important part of the process too, that is hard, not very tangible, but important.
Thanks. Dr. Gould.
I wish I knew. I don't know. I mean, these are self-report, right? So I can't help but wonder, maybe there's something about those kids being more willing to talk about it, but I don't know. The real answer is I don't know. But it is really notable and interesting.
Okay, go ahead, Dr. Laurie.
Summarize the question. What happens when a young person actually does ask for help and the school isn't sure where to point them? Is that accurate? Yeah. It's a good question. I mean, this is by no means the only arm of sort of mental health promotion in schools, nor is it intended to be. So I would hope that the other arms are there. And, you know, and if they're not, maybe it's a time to sort of ignite some of that conversation with whatever school it is. Because this is not a problem that would be created, right? I don't know if that's the most linear answer, but
Yeah, no, that is a tough one. We're just about out of time, and I want to ask you one more quick thing, because I'm a huge fan of Harry Potter, and I'm dying to know what's in the Harry Potter CBT. Why is it? I mean, what's the connection between Harry Potter and CBT?
well, I think so. The third book, Prisoners of Azkaban. I briefly looked at their website, so it's Googleable. I think one of the creators, when they were reading the book with their kid was sort of like, oh, this sounds like CBT. And when you read through the book, you know, the Dementors and
Right.
Yeah, it's
The Dementors, who seem to be the embodiment of depression, is
yeah.
one obvious connection. Yeah.
Yeah, but you can Google it actually, and it'll sort of go through chapter by chapter. It's interesting.
Cool. Well, thanks so much. Terrific round.